Bismillahirrahmanirrahim. One very important topic is spinal tract anatomy and functions. This page and one page behind 508, we have the most important topic from neurology, and every line is an MCQ. So first of all, we have to just look on to general anatomy. We can see here that in the spinal cord we have anterior horn and we have the posterior horn. Anteriorly looking here, we have certain tracts around the interior horn, because interior horn is the place from where the motor neuron starts, or descending pathways are ending on the interior horn cells, and motor neurons starts to move out to supply the muscles. But the posterior horn is very important, because most of the sensory pathways, the senses we take from the skin, for example touch, pain, pressure, ends in the posterior horn, and from here the tracts starts and takes information upside. So what are these tracts of ascending tracts? There are two important ascending tracts. One is the dorsal column, because it is present dorsally, it is called dorsal column, and it ascends all the way in the spinal cord, so makes a column. And the other are lateral and anterior. So they are combined, called anterolateral pathway or anterior and lateral pathways. They takes sensations. Anterior spinothalamic tract takes crude touch, and lateral spinothalamic takes pain and temperature, and they decassate in the spinal cord, while the dorsal column do not decassate in the spinal cord, and they takes most of the sensations like pressure, vibration, fine touch, and proprioception from joints. And they form two nuclei. One is medially, that is gracilis, and the other is cuneatus, laterally. General direction of pathway is that if the lower leg is combined, the pathway first will be going to medially and then adds on laterally for upper limb. So it's understandable that when body is organized, the neurons from downward will be placed medially, and as they ascend, the added on neuron will be from lateral side. So gracilis takes lower body sensations for pressure, vibration, fine touch, and proprioception. This fine touch shouldn't be confused with crude touch, that is the task of anterior spinothalamic tract. And it is written here as well, dorsal columns are organized as you are, with hands at sides, arms outside, legs inside. So this is an MCQ. Now we move on to the main topic, that is the ascending and descending tracts. Most important are the ascending tracts. We know that dorsal column, it is taking the pressure, vibration, fine touch, and proprioception. So two P's, pressure and proprioception from joints. And they decassate in the medulla, because they go all the way through the spinal cord, ascends ipsilaterally in the dorsal column. So this ipsilateral and in the dorsal column are lost, and any lesion will lead to the ipsilateral loss, unlike the anterolateral where they decassate inside the spinal cord, and contralateral, one level below, lesion is seen here. The disease is sensory ataxia, because if one cannot perceive the joint position, he or she will have ataxic gait, and one level and also loss of vibration and fine touch on the same side, one level below, because the entering neuron of first order into the spinal cord joins to the second order, and that uses up one level at least. So one level below symptoms are seen. In dorsal column, it is on the same side because it ascends ipsilaterally, and in anterolateral it is on the opposite side, one level below the lesion. So the decassate, the dorsal column decassate in the medulla and ascends contralaterally. Then they ascend. They do not decassate in the column, rather in the medulla, and form the medial lemniscus inside the brain. So that's why they are called dorsal column medial lemniscal system. So any lesion above the medulla will lead to the contralateral loss of dorsal column function, but most of the questions are asked at the spinal level. And we know another MCQ that pseudo unipolar cells are present in the spinal cord. Here it is written, you can take out this MCQ from here. Otherwise there is no significance of writing down that it bypasses pseudo unipolar from exam point of view. Only thing is that pseudo unipolar neurons are in the spinal cord. And now moving on to the Romberg positivity, as we know that for balance, our eyes, our vestibular system, and our joint position sensing, all three work together, and at least two of them should be working. So if we close eyes, we can maintain usually the balance because joints are sensing and our vestibular system are working. But if we close eyes and our joint position senses due to dorsal column lesions are not working, so only one vestibular or inner ear cannot maintain the balance and we will sway away or will fall. This is called Romberg positivity, that falling on closing eyes, because one system is knocked out and the second is knocked out when we close eyes. So it is seen in sensory ataxia, for example dorsal column medial lemniscal system ataxia, versus if person falls on open eyes as well, so that is the lesion of cerebellar, and cerebellar lesion there is no Romberg positivity seen that the falling on closing eyes, because patient falls on both closing and opening of eyes, because cerebellum is concerned with balance as well. So these MCQs are asked for Romberg positivity, and we should know the pathophysiology so we can make out it. And other thing, nucleus gracilis and cuneatus, gracilis for legs, cuneatus for arm, we already covered. And inside the after decussating in the medulla, all pathways ends into the thalamus, and we know that it is a ventroposterolateral nucleus for all body pathways, and ventroposteromedial for face, for trigeminal nerve, and for chorda tympani facial nerve. And here it is ventroposterolateral, and the second order neuron nuclei makes the thalamus or ventroposterolateral nucleus, that is asked. Now moving on to the spinothalamic tract, that are anterior and lateral. The lateral is for pain and temperature, and aid, we know that A delta is for fast pain, C is for slow pain, and they ascend ipsilaterally for a while and then decussate in the spinal cord one level above. So any lesion will lead to loss of pain and temperature on opposite side of lesion one level below. This is the difference between dorsal column and lateral or anterolateral system, that anterolateral decussate inside the spinal cord. So any lesion in spinal cord will lead to opposite side loss of pain and temperature versus same side loss of pressure proprioception in dorsal column. So anterior is for crude touch, that is another MCQ. We do not have to confuse it with fine touch, that is dorsal column, we already know. And for descending tract, it is the lateral corticospinal tract. Cortex means it starts from brain, descending tract ends into the spinal cord, and we know that the first order neuron will be in the cerebral cortex and passes through the internal capsule. It is not to be confused with the decussation in medulla of the dorsal column. It is internal capsule is a different thing. In the posterior limb, descending tracts in the posterior limb, and ascending tracts goes through the interior. I think it is opposite to general orientation of body, where motor tracts are in the interior column of the spinal cord versus sensory in the posterior. In the internal capsule, the descending or motor tracts are in the posterior limb, and that is asked in question. And the decussate at caudal medulla, that forms the pyramidal decussation. That's why lateral corticospinal or anterior corticospinal tracts are generally called pyramidal tracts, and other tracts related to the motor function are called extrapyramidal tracts, and they descend contralaterally. So any lesion in the brain will lead to the motor loss on the opposite side of the body. That's why brain controls opposite side, and they could decussate at the level of medulla, ends on the anterior horn, spinal cord, and then your neuromuscular junction controls the muscle. So these are ascending and descending tracts. You have to know the anatomy as well, so you can easily answer the questions. And one more thing, that this intermediate horn has sympathetic fibers, just like the anterior and posterior horn. There is an intermediate horn in T1 to L2 or L3 level. It is the sympathetic horn. That's why sympathetic has a thoracolumbar origin, that is T1 to T12, and then L1 and L2 and up to L3 sometimes. So this is another MCQ. It is written here, so it is needed to be covered here as well. Thank you.